Hello, everyone. My name is Dr. Hester Lim. I'm from the Philippine Dermatological Society, and today I'll be talking about the topic Mpox Revisited, updates in clinical knowledge and differential diagnoses for this particular condition. So I have no conflicts of interest to disclose for this particular topic. Now, to a dermatologist, a rash can be broken down into many different components. We look at the primary morphology. Is it a papule? Is it a macule? Is it a plaque? We look at secondary morphology. We look at color, configuration, the distribution, and other symptoms of the patient. So morphology is very, very important in the diagnostic pathway for dermatology. And I will be emphasizing it a lot in the diagnostic pathway for recognizing conditions like Mpox. Of course, the eyes do not see what the mind does not know. So let's talk a little bit about Mpox as a condition. So one of the biggest changes you may have noticed was back in 2022, we used to refer to Mpox as monkeypox, right? However, the WHO recommended a new name to decrease the stigma of this condition. However, throughout this lecture, I will be talking or calling it Mpox and monkeypox interchangeably. Now, Mpox, also known as human monkeypox, is a zoonosis caused by the monkeypox virus. So this is a double-stranded DNA virus of the family Poxviridae. Now, the term monkeypox is misleading because while it was first recognized in captive monkeys, rodents are actually the largest animal reservoir for the virus. Now, when we talk about Mpox, we have to know about how the classic appearance of the rash looks like versus how the rash looked like in various points in time, like in the 2003 outbreak, and more importantly, the 2022 outbreak. So classic Mpox was first recognized or described in Africa. Very often in these portions of Africa, they were transmitted either through by hunter-gatherers who were in direct contact with animals who had the condition, or individuals who ate infected meat. And so you can see a very widespread disseminated rash, very monomorphic, papular in appearance, and very significant lymphadenopathy. These are other pictures from the Nigerian Center for Disease Control. And when we talk about Mpox, we have to understand the clinical differences between the two clades. So first is the Congo Basin clade, which is responsible for clade 1. So this was changed to clade 1. And clade 1 is primarily responsible for severe disease. So in the photos I shared earlier of the children with very disseminated Mpox, this is most likely caused by the Congo Basin clade, whereas the West African clade is classically responsible for milder disease. And this is also known as clade 2. In fact, it was clade 2B that drove the 2022 outbreak. Now, to this time, if you look at this graph from CDC, you can see in blue circles where Mpox was previously reported to be endemic. So this is, again, Central and West Africa. And you can see the orange circles where Mpox was previously never reported and is now currently present. And of course, in the Philippines, we have our own cases of Mpox as well. So Mpox has been detected in almost every continent worldwide. And you can see primarily if you describe the clades, this is primarily going to be the clade 2. Again, the driving factor behind the 2022 spread of Mpox. But you can see that clade 1A has actually spread outside of its original territory in Central Africa. So the 2022 outbreak was described as the largest outbreak outside of Africa. And so the WHO did grant it an emergency status back in July 2022, but they ended it in May 2023. And the reason they initially started the public health emergency status was because they were able to recognize human-to-human transmission of the condition. However, in 2022, this is really driven by clade 2B. They had a majority of male cases and with varying clinical appearances compared to classic Mpox. However, in August 2024, the public health emergency status was reinstated by the WHO. And this was because the upsurge of cases in the Democratic Republic of Congo, and in fact, a spillover of clade 1A beyond Congo, where it was classically endemic. So they found that there were a lot more clade 1A cases, primarily in children, And they also recognized clade 1B, which was a new strain they found in early 2024. So because of this, the WHO reinstated the public health emergency status. Now, what happens with Mpox? Of course, the infection occurs when there is viral exposure and entry into mucous membranes and broken skin. There is an incubation period of 1 to 2 weeks and a prodrome period of 3 to 4 days. And it's during this prodromal period where patients will manifest with fever, chills, headache, myalgia, and lymphadenopathy. Subsequently, they then develop cutaneous symptoms over the next 2 to 4 weeks. So with cutaneous symptoms, the rashes can appear at the site of entry or exposure, and patients will have vesicles and pustules, which subsequently umbilicate, crust, and then desquamate. So oral and genital mucous membranes are often involved. Now, as clinicians, I gathered here a variety of symptoms based on case series and cross-sectional studies published based on the 2022 outbreaks, so we can recognize as clinicians, what are we supposed to be looking for? In fact, 95 to 100% will present with skin manifestations. And this really highlights the role of the dermatologist and, in fact, the dermatological exam by non-dermatologists. So for skin manifestations, we are looking for vesicles, pustules, and papules, very often in the genital location. However, this depends on the mode of transmission. And in 80 to 89% of patients, they actually had less than 25 lesions. So we are not looking for lesions in the hundreds, as was previously described with classic monkeypox cases. Another common symptom we're looking for is lymphadenopathy. Regional lymphadenopathy tends to be the most common. And of course, we also ask for fever, which is particularly important. So I'll be sharing this slide showing the various terms that we often use in dermatology to describe the morphology of a rash. So you can see macules and patches, papules, plaques, nodules, vesicles, and bullae, as well as the various secondary morphologic changes we often describe in dermatology. But of special mention, I will be repeatedly using the terms papule, which is used to describe a small elevation, palpable elevation within the skin, vesicles, which means there is fluid in these elevations, and pustules, meaning these are pus-filled. Now, very important to assess in the history of the patient is what did the lesions look like and how did they change over time, or the evolution of the lesions. Very often, patients will describe vesicles at first, followed by the development of pustules, followed by crust formation. And these are, in fact, very common changes you see in diseases where vesicles are predominant, and not only in conditions like Mpox. I also use the term umbilication very frequently, and it's exactly what it sounds like. That means a central dip within a papule. So very often you'll see umbilication in even conditions like chickenpox in this first picture, in conditions like Mpox, and then of course, classically, you'll hear about central umbilication in a condition like molluscum contagiosum. So what are the other things we look for? Very interesting in this outbreak in this article describing the outbreak in Spain, was the characteristic pseudopustules at the suspected inoculation site. So in the suspected inoculation site, they found that the areas that looked like pustules were in fact not fluid filled at all. So when they tried to get a swab, they found that there was no roof or liquid content in these areas at all. And there were a few number of pseudopustules in the area, primarily localized to a single site. And many patients had a secondary eruption, followed by the development of true pustules and an erythematous halo. So a lot of these patients developed an asynchronous development of rashes. Now, the CDC also recommends, also describes the different lesions in Mpox. So they describe first an early vesicle, followed by the development of a pustule, which then becomes umbilicated over time, which then becomes ulcerated over time, later on developing a crust and then a partially removed scab. Lesions, particularly in Mpox, have been described to be firm or rubbery, very deep-seated, and again, characteristically having a central umbilication, even with the smallest pustules. The evolution, again, as I mentioned, is particularly important because we are looking for things changing from a macule to a papule to a vesicle to a pustule, followed by scabbing and desquamation. Other aspects of symptomatology are also very important when assessing a patient with Mpox. So a lot of patients, because of the mode of transmission, will have rectal symptoms. So many will complain of purulent or bloody stools, severe rectal pain. And in fact, this actually drove a lot of patients to become admitted. This is frequently reported in the 2022 outbreak. And of course, again, as I mentioned previously, we have fever and other prodromal symptoms that can occur before the rash, but it can also occur after the rash, but in many cases, not present at all. One thing that the CDC did emphasize was that during the current global outbreak, they found that the lesions often, but not always, occurred in the genital and anal rectal areas or in the mouth. Again, this is often reflective of the mode of transmission. The rash is not always disseminated across many sites on the body, as classic monkeypox was described. The rash can, in fact, be confined to only a few lesions or even only a single lesion in some cases. And the rash did not always appear on the palms and soles. So again, just a picture here showing classic Mpox, comparing it to the 2022 outbreak patients. So in classic Mpox, we're seeing more than 100 lesions in about half of the patients. And then in the 2022 outbreak, of course, driven by clade 2B, we had patients with less than 25 lesions. So again, generally a milder clinical appearance overall. But as physicians, how do we then develop differential diagnoses for this condition? So it's very important to assess first, are you looking at a disseminated rash or are you looking at a localized rash? Because this can help you break down your differential conditions. If you're seeing something very widespread, of course, always ask for a fever. If the patient does have fever, you have a few conditions here you can consider. If the patient does not have fever, you can have a few conditions here as well. And of course, for localized lesions, it's also important to identify whether you're dealing with vesicles, pustules, papules, or ulcers. And in fact, you still have to assess morphology when we are considering differential diagnoses for febrile patients as well. So for example, I want you to look at the pictures A, B, and C, and which one do you think here is Mpox? So in fact, A is a very classic case of chickenpox. B, in fact, is disseminated herpes zoster, and C is the Mpox case. So chickenpox is one of the most important differential diagnoses when you're having a patient with a widespread vesicopustular rash and fever. Patients with chickenpox tend to have a shorter, milder prodrome. They do not commonly have significant lymphadenopathy, and the rash is characterized as being centripetally distributed, meaning it's primarily going to be on the trunk first before it spreads to the extremities. You will see classically vesicles on an erythematous base, although over time, as I mentioned in the previous slide, vesicles can become pustular as well. Disseminated herpes zoster was in that second photo I shared. And yes, these patients will often still have a disseminated vesicopustular rash and a fever. And importantly, they do often present with lymphadenopathy. However, the giveaway in that photo I shared were these clustered vesicles around the sort of umbilicated lesions we saw. And these clustered vesicles are really one of the characteristic lesions for herpetiform conditions, meaning your herpes zoster, herpes simplex. Now with disseminated zoster, you're going to have a classic zoster appearance or classic shingles appearance where you have dermatomal involvement, and the patient will have 1 to 2 dermatomes affected before it generalizes in disseminated cases. And in HSP, disseminated herpes simplex, the primary involvement will often begin in a mucocutaneous area, whether it's genital or oral, and in both, they may have visceral involvement as well. Now, what about localized genital lesions? We see A, B, C, or D. Okay, C and D are in fact the Mpox cases, and A and B are in fact herpes cases. Now, if you look at A, B, and C here, I think it's easier for you to recognize that definitely see is the Mpox case. And if you look at the close-up lesions of A and B, we are again seeing clustered vesicles. So when we see clustered vesicles, it's very classic, as I said, for herpes. Whereas in your Mpox, we're seeing an umbilicated lesion here. And of course, that central ulceration that appears very umbilicated, and it's localized. So for your herpes simplex, this will present as a localized vesicopustular rash over the lips or the genitals, and it tends to be classically very painful. So that's what makes it a little similar to Mpox, in that it's quite a painful lesion to begin with. Now, because we have some nerve involvement with herpes simplex, patients will often report a prodrome of tingling, itching, burning, or pain. This tends to occur in clusters of vesicles. So again, I'm just showing a picture of these grapes to remind you what these clusters can look like. And it tends to be very limited in distribution. One of the important things to ask for is if your patient has had previous episodes before, because that's also a giveaway. Recurrent cases are very common in herpes simplex. If you see A and B, the lesions are actually quite similar. You see, in fact, significant central umbilication in A. However, A is actually your herpes zoster or your shingles. So you can see that the lesions here are not particularly synchronous. So you can see that they're in different stages of development. You have some fresh vesicles here. And you have actually, if you look at these lesions here on the thigh, this is actually going to be a dermatomal rash, perhaps in a few days. So you can see early lesions here, and these are later lesions here. So they're definitely asynchronous. They're not developing all together. Whereas in B, we have just a single lesion, single painful lesion. So for herpes zoster, you'll have localized vesicopustular rash, very painful. And again, we are looking for a dermatomal distribution that does not cross the midline. So you see, again, these clusters of vesicles. Sometimes you'll see them in different stages of development, as in that first picture. Now, what about A, B, C, or D? The question here is which one is not Mpox? Because A, B, and C are Mpox, and D is in fact molluscum contagiosum. So you can see that A actually looks very non-specific. It almost looks like folliculitis or acne. But B or C, this is actually Mpox in immunocompromised cases. And so you can see that the appearance is much more severe, very, very florid. But classically, these lesions are monomorphic, meaning they're around the same stage of development. And we have these umbilicated lesions. Now in D, we still see umbilicated lesions, which are classic. This is also molluscum in an immunocompromised host as well. So molluscum contagiosum is the classic umbilicated rash in dermatology, actually. You'll see a localized papular rash, very often itchy and red, and it commonly will affect children, but it can be very widespread in immunocompromised populations. And in adults, very often this will be sexually transmitted. So this can show up on the face and genitals, very much like Mpox. But these present with papules that have a solid white, almost like a keratinous substance when these are squeezed out. Now, again, you can see pictures here, A, B, C, or D. And in fact, A and B might look familiar to you already. These are cases of Mpox, and C and D are simple folliculitis cases. So again, there are a lot of less concerning differentials that can occur in patients with a rash. So it's not always going to be Mpox. So very important tips in dermatology. Make sure you do a very full exam. Don't forget to examine the oral mucosa because this is still part of the dermatologic exam. And of course, in Mpox, remember to look for lymphadenopathy. Palpate with gloved hands. Consider other symptoms. Consider risk factors if you're a patient, especially with the 2022 outbreak. The majority of the cases have been sexually transmitted. However, you can always assess for other possible risk factors for your patient as well. And of course, review the timeline of symptoms and review the evolution of the rash. What did it look like when it first began is a very, very important question. Was it a macule, a papule, a vesicle, a pustule? And one of my closing sentiments is that there are many, many non-infectious skin diseases that will appear with blisters, papules, or pustules, conditions like pustular psoriasis, where these patients are febrile with numerous pustules, or conditions like bullous pemphigoid. Again, these are all autoimmune conditions. Neurofibromatosis is a genetic condition, and yet all these patients are burdened with the stigma for skin disease. So, of course, when in doubt, when you are unsure, please refer to your friendly neighborhood board certified dermatologist. Thank you very much for your kind attention, and these are my references.